Well, hey, everybody, this is Robert, and welcome to Outbreak News Interviews. Now, rapid data collection can provide an insight into causation, the socio-cultural reality, and complex social processes. This is especially important in disease outbreaks when information is quickly required on local needs that is essential for success. Now, my guest today will discuss rapid data collection and how it's applied to a hantavirus outbreak in Argentina. He will also discuss its use in context with Ebola. So joining me today is Glenn Laverack, PhD. Dr. Laverack is a professor at the College of Medicine and Health Sciences, Institute of Public Health at UAE University. He is also the author of a number of books on health promotion and outbreaks. Dr. Laverack, welcome back to the show, sir.
Thank you, Robert. Nice to be back.
Well, let's, when you talk about rapid data collection, this is for me and for the audience. What specifically are you referring to?
Well, in this context, I'm referring to a tried and tested approach that's rapid and discrete. That's important, has minimal interference, uses a small team, and can be done at low cost, but potentially the findings can have a profound impact on the success of a program. That's what I found. Basically, the purpose is to collect and analyze information and to translate this into operational recommendations. This is a key point. This is often a missing link I find in program implementation. It uses a mixed methods approach, and I've used it myself over many years, over many projects in many countries. And so it's been slowly adapted. And now we've got, and that's why I published this paper. Now we have an approach that I think really works.
So prior to this, has this been something that has been tried and with certain degrees of success in the past?
Yes, I mean, there are other, there have been other methods. I mean, I guess, historically, this sort of approach would be called a quick and dirty approach, but I don't think that term was very popular. I don't think it ever caught on in public health. But essentially, that's what we're talking about. I mean, it's in a way it's contrary to the slow science approach, to the empirical approach, because as you know, in a disease outbreak, any disease outbreak almost, things change on a daily basis. You know, the environment is constantly changing. And small amounts of information coming in on a regular basis about behavior, accessing services, for example, transmission, reporting of cases can really make a big difference. So it's essentially what it's getting at is the art and science of public health. You know, the science is the evidence that we have in its different forms. The art is how we translate that into something that's useful in practice.
Okay, so you mentioned some of the strengths right there. What are some of the real or perceived weaknesses of this approach?
Yeah, well, the strengths are that, as you were saying, it's discrete and minimal interference, and it's low cost. And it does raise an issue about basic skill sets, which we can maybe talk a little bit about within public health that I think need to be addressed and are important. But from my experience of using this in practice, probably the biggest drawback is the amount of time you have in the field to do this. I mean, it's quick by definition, you know. So, for example, the study I'm going to talk about that we did in Argentina with hantavirus, we did it from start to finish in 5 days. So that means you have a limited amount of time on the ground, which means you have limited access to interviewees, limited access to data, limited access to places, because, you know, the weather, the terrain can all cut your time down on how you get to places to carry out to collect your primary data. So I think for me, the other weakness is that some people may say that this is largely anecdotal evidence, and that it's not very profound, it's not empirical. But to me, in my experience in working in disease outbreaks, you know, we need information on the ground. We need that quickly, and we need it as it's changing. So we don't have time for the slow science, for anthropological studies, for empirical studies. They play an incredibly significant role. Don't get me wrong. I mean, well, we'll talk about Ebola in a minute. I'll talk about that, but they play that evidence plays a very big role. But I think on the ground we need something quicker and more responsive.
So this is actually a set of processes. Dr. Laverack, can you discuss the various phases of this process?
Yeah, it's well, as it's outlined in the paper, it's a sort of 5-phase process. We start off with a rapid review of the literature. There are various ways we can do that. I tend to use the guidelines set out by the Health Evidence Network, WHO's Health Evidence Network, report number 50. It's a free download, which talks about how to do a rapid review. This is one of the basic skill sets I was talking about, which I think is often lacking. I use this often in my work, this method, but I find that many people I work with don't understand how to do this. The second and third parts are collecting primary data sources through focus groups and one-to-one interviews, and of course, observation on the ground. And again, these qualitative, interpreting epidemiological data is a skill that we often get, I think, through our university training. But how to conduct a simple focus group or a simple one-to-one interview, and then how to interpret that data and turn that into something useful is, again, a basic skill set that I think is often missing. People don't have the confidence, let alone the competence to do that, in public health. And then the fourth part is an analysis of the secondary and the primary sources of data. Because we're talking about small amounts of data, I often just use a simple cut and paste categorization of the information. And then this can be used for the synthesis of recommendations, programmatic recommendations. And I think this is often a missing link, because I'm a researcher myself. I'm also a program manager. And I know very good researchers, I know very good program managers, but I don't know many people that are able to take that evidence, that information, and translate it into something that is useful in a programmatic context. By that I mean something that can be delivered, can be implemented, or can be used for evaluation. This is also a basic skill set that I think we need to work on in public health.
Okay, now in the case study that was published in the Journal of Public Health, Hygiene, and Safety, you detail the use of rapid data collection in Patagonia, Argentina during a hantavirus outbreak.
Yeah.
Dr. Laverack, can you go ahead and discuss the process and the outcome?
Right. Well, just to put this into context, as I say, it was a 5-day process. There were 2 people, myself and Dr. Jaime, who was a public health practitioner. We interviewed 32 people over this period, as well as doing the literature review, and we carried out a number of observations on the ground. It was done in the Comacha region, which is a mountainous region in the western part of the Chubut province, on the border with Rio Negro in Patagonia, on the Chilean border. And it's an area of natural forest, which is also a great habitat for the mouse species, which transmits hantavirus. And I'm sure many of the listeners will be aware about hantavirus because it's been an issue that's been in the news quite recently, hasn't it? Yeah.
Yes.
But in this area, there's also an international airport, and there's also a lot of seasonal workers, and a lot of people come there for recreational purposes. So we felt that, it was worth looking at, not so much for hantavirus, because as you know, this is a zoonotic transmission from mice, mostly through feces and urine. It can be inhaled through droplets, but through cuts and abrasions. But also in this part of the Comacha, there is also another strain of the hantavirus, which is the Andes orthohantavirus, which causes a serious pulmonary syndrome, and it has about a 30% fatality. And again, it's zoonotic transmission, but most importantly, it can be transmitted between humans in droplets. Right. So I can see you nodding your head, so you know about this.
Yeah.
So we felt that potentially there could be an international outbreak, of Andes virus from a local source in this region. So we wanted to look at how authorities were working with communities to manage and prevent the spread of this disease. We felt it was important. So we looked at five municipalities, and we found that the highest prevalence of hantavirus in this area was in the poorest communities, and also those communities had the least cohesion, the least community cohesion as a community, and often actually were situated very close, literally, on the edge of the forest. So for economic reasons, people would go into the forest to pick mushrooms and to pick berries to sell or to eat themselves. One berry in particular, called Rosa mosqueta, is a little red berry, which is very popular, but it's also very popular with the mice that spread hantavirus. Mm-hmm. And we went into the forest to look, and these are thorny bushes, and, you catch your clothes, and it's very easy to see how someone picking these berries would get a cut or an abrasion right in the place where the mice are also, eating berries, defecating, and, urinating. So a high level of transmission. But there are also tourist or recreational hotspots in this area. We went there as well, where you've got your picnic benches and your barbecues next to a lake, and then right next to that you've got the forest, and you can see the tracks, where people are going in. And we spoke to residents in the forest, and they confirmed that there are many tourists that come and pick berries, and there are many, many mice. They're infested with these mice, so it is a high risk for transmission. We can see that. So we did our literature review. We interviewed the authorities, public health, the town mayor, community members, and all that information we were able to put together a set of recommendations which we felt would help the local authorities to develop a more cohesive plan. And that included identifying community and local representatives from each municipality, then creating a local coordination group to talk about, how that affects the community, what the local behaviors are, how people, because it's endemic, there is a low level of risk perception that this is a problem. But here we're talking about Andes virus, remember, not hantavirus. Right. And also we found that the local authorities play down. There are cases every year of hantavirus, but the local authorities play this down because they don't want to affect the tourism industry. So with this low level of perception, people are not aware. There are no signs like you may get for something like Lyme disease, saying don't be careful there's no signs, there's no fencing, there's easy access. So we felt that it would be good to talk at a local level about how they could reduce prevention, and then have an overarching central coordination group across all the 5 municipalities with the public health authorities that could meet to talk about the commonalities and the problems and talk about broader campaigns and strategies. But as part of this, there needed to be some basic training around strategic planning and community engagement, which was part of these recommendations, and an ongoing monitoring progress on how this was developing. Because we did feel, our conclusion was that all the factors exist for there to be an international outbreak of Andes virus that could come from this area, in terms of poverty, population movement, endemic hantavirus, the mice, everything. So we did feel it was necessary for further investigation. We just did this quick and easy approach, which gave us a lot of valuable information. Mm-hmm. But we felt there should be a further investigation looking at the complex social, economic, and organizational, in terms of the authorities, factors to develop something more cohesive in this area in Patagonia.
Oh, very interesting. Dr. Laverack, you also mentioned to me prior to the show that this could be useful also in the context of an Ebola outbreak. Would you like to elaborate on that?
Yeah, well, Ebola, or I think almost any disease outbreak, would benefit from this type of an approach. If there were people on the ground with these sorts of basic skill sets, if we can do it over 5 days, I'm sure anyone could do it over a short period of time and come out with a good set of recommendations. And that's what's missing. When I was a community engagement coordinator for UNMIA across the 3 affected countries during the West African outbreak in Liberia, Sierra Leone, and Guinea. So I saw it across the 3 countries, and I met many researchers at that time that were there collecting data from different organizations and universities around the world, but very few of them, hardly any of them, were willing to share their findings. You know, they had this information, they were taking it away back to their university, and they were going to publish a paper in, you know, a year to 2 years. That's not useful to the people on the ground that are trying to deal with the Ebola outbreak, which is literally changing on a daily basis. You know, so that gives an indication that although, you know, slow science, anthropological science is very important, and this is a book that by 2 authors from Washington, D.C., Hewlett and Hewlett, that wrote about the anthropology of an emerging disease. This was in 2008, and this was about Ebola. And I've read this book so many times because it gave me so much insight into what was happening culturally, politically, you know, socially in West Africa, even though this book is based on case studies and experience from Uganda and the Congo on the other side of Africa. It was still useful. So there is a big, you know, it's very useful to have this type of data, but on the ground, on that day, you know, when there is a cluster outbreak and you need to know why, this is why this quick and easy approach can be very, very helpful about rumors and behaviors and community involvement and, you know, cross-border movements and all sorts of different things in the context of Ebola. I'm not saying that this data should drive the response by any means. It should supplement an outbreak response where needed. And I saw myself many examples, and I've seen myself many examples in many other contexts, not just outbreaks, but in other contexts where information, even if it is relatively quick, and I know that many researchers I know would be upset by what I'm saying because they would say all research should be empirical research. But, you know, the reality, and this is why I say it's not just about being scientifically right, it's about being real. And if you understand the reality of an outbreak, you'll understand that we can't wait around, you know, for your findings to be. And also, to be honest, many of the findings I did get my hands on with the Ebola outbreak were thick, dense, you know, data, the interview data, and no program manager has the time or probably the skills to interpret that data and to put that into how it's going to change, you know, your messaging or you know, people hiding dead bodies or people not taking people with illness to the hospital. How you're going to change that type of behavior. From that thick dead. So you need somebody that can take, you need someone with a subset of skills that can take that qualitative data and the quantitative data and translate that into an easily digestible and implementable set of recommendations. And I think this is a key area we are lacking in public health, particularly in the context of outbreaks.
Okay, well, let's go ahead and wrap it up right now, Dr. Laverack. I'll give you an open floor to just any final thoughts on this topic.
I think really I'll just go back to those 3 key points I was saying about bridging the gap between research and practice in outbreaks. You know, that we need to think carefully about how to do this, how to translate that and make it into useful recommendations. We need more quick and easy methods that can help us bridge that gap. And we need to think carefully about using these basic skill sets like rapid literature reviews, as well as the interpretation of quantitative data, the use of qualitative methods, and the synthesis of all these findings. We need to think about this more in how we train our public health practitioners, or, I mean, it doesn't need somebody with a postgraduate qualification. I mean, this could be done, you know, what I'm talking about, this quick and easy approach could be easily carried out by community health workers with a little bit of training. And so long as that information that the program managers and the planners receive is taken in context, you know, that it is rapid, that it has been carried out in that way, then it can be used along with other information, to have, as I say, quite a profound impact on the success of programs.
All right, very good. Again, everybody, the case study, it's entitled The Challenge of Rapid Data Collection and Health Promotion, a Quick and Easy Approach. It's published in the Journal of Public Health, Hygiene, and Safety. And I'll link to it in the show notes if you want to go ahead and check it out. And I want to thank you, Dr. Glenn Laverack, for sharing your time and expertise today, sir.
Thank you very much.